Today I am presenting a 3-view wrist. The image modality is X-ray. The date of exam is June 5th, 2020. The reason for the exam was the patient was having pain. The projections are PA, oblique, and lateral. The patient was a 20-year-old female. She came into the department ambulatory. The physician findings were normal, no significant arthropathy or acute abnormality. The exam was done on a digital Carestream cassette, 14x17, tabletop with no grid. The PA was done at 60 kVp at 2.5 mass, and the lateral was 60 kVp at 4 mass. And the SID was 40 inches. You are hopefully able to see that there was proper diagnostic exposure quality, because you can see the periosteum and the trabecular markings in the radius and ulna. You can also see the periosteum in the metacarpals along with the trabecular markings. My EI number was 2016. For Carestream, all exams should be within 15 to 1800 and extremities should fall about at 2000. So it was in range for proper diagnostic. For all projections, my patient was upright and sitting in a chair. So for the PA position, the patient's anterior palmar surface was on the cassette. The shoulder, elbow, wrist were in the same plane. The carpals were in the middle of the cassette, and the central ray was directed at the mid-carpal area. The collimation was to include the metacarpals and the distal radius and ulna. For the oblique, again, the shoulder, elbow, and wrist need to be in the same horizontal plane. From the PA position, you rotate the hand laterally 45 degrees. Again, you want the central ray to the mid-carpal area, and collimation to include the metacarpals and the distal radius and ulna. For the patient position for the lateral, the shoulder, elbow, and wrist still need to be in the same horizontal plane. You rotate the hand into a true lateral. A true lateral is evidenced by the ulnar head being superimposed by the distal radius. So this is the ulnar head, the distal radius, so they're superimposed. The central ray is to the mid-carpal area, which is right there. And then the collimation is to include the metacarpals and the distal radius and ulna. I did not need to use any immobilizations or any other equipment. I had no challenges or had to make any certain adaptations to the exam. After showing these images, they are of positioning quality, so they are diagnostic quality. In the PA projection, you can see the first metacarpal, the second metacarpal, third metacarpal, fourth metacarpal, and fifth metacarpal. You can see the trapezium, the trapezoid, the capitate, the hamate, the scaphoid, the lunate, the triquetrum, and the pisiform. This is the radius, and this is the ulna. In the oblique wrist, you can see the first metacarpal, second metacarpal, third metacarpal, and then the fourth and the fifth metacarpals are superimposed. You can see the trapezium, the trapezoid, the capitate and hamate are superimposed, the scaphoid, and then the lunate, triquetrum, and pisiform are superimposed, and then the radius and the ulna. In the lateral projection, you can see the first metacarpal, the second metacarpal, and the third, fourth, and fifth metacarpals are superimposed. You can see the trapezium and you can see the scaphoid. The other carpals are superimposed. And you can also see the radius and the ulna. You can also see in each of my projections that soft tissue is visible. And for my radiation safety, I shielded the patient's gonads with a lead shield, and I also collimated to the anatomy of interest.